Hi guys, welcome back to another episode of Ask Dr. Nick. My name is Nick Schmidlkoffer, Dr. Nick Schmidlkoffer, and I work for the Neurologic Wellness Institute in downtown Chicago. And on today's episode, we are going to talk about, is cholesterol bad? And there's a big stigma in the traditional healthcare world that we want to avoid cholesterol, that cholesterol is the plague. It causes heart disease, it causes plaquing of the arteries along with saturated fat. And so I want to take a little dive into some studies that show maybe it's not all bad. Where cholesterol first got its this reputation is from this Framingham study. It was a study in Framingham, Massachusetts that started in the 1950s and then looked at people 30 years out, and they correlated LDL cholesterol, or low density lipoprotein cholesterol, with heart disease. But the problem is there weren't many it wasn't an independent risk factor. And there's been many other studies to kind of show that maybe it wasn't simply the LDL cholesterol, maybe there were other factors as well correlated with that. And again, these are epidemiological studies. So epidemiological studies are basically studies that aren't controlled. We just look at people who either eat a bunch of cholesterol or eat a bunch of fatty foods, and then those who don't. And we may not actually correlate, or may not, they are correlation studies. We may not actually take into account factors of other healthy living, like not smoking or exercising, getting out in the sun, those kind of factors. So I just want to show a couple articles, and I want to take first a little intro into what are lipoproteins, what is LDL, what is HDL, what is cholesterol, and then how atherosclerotic plaque actually forms, and then why LDL may be good, maybe actually good for this component. So let's get right into it. First thing I'm going to do is we're going to talk a little bit about the different lipoproteins. And so here they are. So when we eat fat, or when we make fat in our liver, they can't be just given right into the blood, because fat into the blood is going to aggregate. They're going to clump together. If you ever put like oil and water together in a bottle, generally the oil goes to one part, or the bottom, and the water goes to the top. They separate, okay? And that's because like enjoys like. And so fat's going to aggregate, clump together, and that could cause a fatty embolism, or fat droplet that can clog an artery. So instead what happens is when we eat fat, we eat cholesterol, it gets put into this chylomicron. And so this chylomicron basically has a lot of triglycerides, a lot of fat from what we eat. That's right there, triglycerides. And then it has a little bit of phospholipids, another type of fat, some free cholesterol, and then these apolipoproteins. Apolipoproteins are the proteins that are on the outside, this green part. This protein structure basically allows this protein structure, along with these pink phospholipid heads, allow the molecule to move around in the blood without aggregating together. It becomes more hydrophilic. It likes water, likes the blood and the plasma. And so this allows these fats to basically move around in our bloodstream. And so when we eat dietary fat, dietary cholesterol, they get packaged in these chylomicrons, and the chylomicrons take it to different areas in the body that need fat for energy, need cholesterol to produce our sex hormones like testosterone, estrogen, progesterone, vitamin D, cortisol, all those hormones. And so, and also to kind of fill our cell membrane. 25% of our cell membranes is made of cholesterol. And then on the other hand, when we eat too many carbs and there's an excess of carbohydrate, a lot of times that pushes us into making cholesterol. And so our liver is going to make cholesterol and then package it in these VLDLs, these very low density lipoproteins. They're very low density because they're bigger and they have more fat in them. They have more triglycerides. They have more cholesterol. and that is all from being made in the liver. And then as very low density lipoproteins drop off these triglycerides into different areas in our body, like tissues that need it for energy, they become intermediate density lipoproteins, IDL, and then low density lipoproteins. These have, you can see, a lot more cholesterol compared to the triglycerides, and then eventually high density lipoproteins, HDLs, which again have very low triglyceride numbers, but then more cholesterol. Okay, so basically this is just a continuum of these lipoproteins that are just dropping off triglycerides into different areas in our body, to different cells that need them for energy. And then we come up with these HDL. We see HDL is normally termed the good cholesterol, versus LDL is normally termed the bad cholesterol, along with these other ones. I kind of want to get away from these terms here. So what happens in like an atherosclerotic plaque? And so in an artery, when we have an artery is kind of subject to a lot of pressure because our heart rate is constantly moving. We have high blood pressure, low blood pressure, but especially these branch points have, there's more pressure that occurs at branch points in arteries. And so we have three layers of the artery. We have an endothelium, then we have a tunica media that has more like smooth muscle to contract, and then a tunica externa. Okay, the endothelium is a lot of times what can get ripped or torn when we have high pressure loads. And so what happens is this torn endothelium, this torn cell layer that's very thin, needs to get repaired. And so a lot of times what happens is these LDL particles, which I'll show you why, can actually go there and try to help with repair. And they help to repair this formation, this breakage. But eventually what will happen is there might be accumulation of these LDL particles, and they get stuck there. And then as they get stuck, it kind of gets bigger and bigger. And during this whole time, we have what's called these foam cells. So macrophages, which are parts of the immune system, are going to go and try to gobble up these LDLs. What happens is LDL is supposed to go there to help protect and help heal the artery, and then come back out. They go in and out of arteries all the time. But if they get there and they get stuck, like they're just not actually performing the function that needs to happen to close that artery, then they can become oxidized. This oxidized LDL is what happens when fats are just kind of hanging around, especially when they're filled with a lot of polyunsaturated fats. Fatty acids that are going to have double bonds that electrons, they're very unstable. And when they become oxidized, these macrophages want to get rid of them because they're no longer functional. And when the macrophages eat them, they can't really get rid of the substance of the oxidized LDL, so they become foam cells. And those foam cells just kind of sit there and continue to build up these lipids. So basically we have this just accumulation of this fatty streak, and then all of a sudden you have this fibrotic core that surrounds the fat. And then later, if we have another break because there's more pressure, that's where you get like a thrombosis, and that's where you can get maybe a stroke, or that thrombosis can go and clog another artery or a smaller artery. And so this can happen from very early on in life to the 4th, 5th, 6th decade as we go. But I just really want to emphasize that the LDL is going there to help the tissue rather than actually cause a clot. The LDL is not made by your body to cause clotting. It's made by your body to help. And so this is where I want to go with just a few articles. First one is, this is a pretty old article. It's from 1996, I believe. We'll go down. It's called "The Lack of Association Between Cholesterol and Coronary Heart Disease, Mortality, Morbidity, and All-Cause Mortality in People Older than 70. And so with almost 1,000 subjects, 4-year incidence, they looked at cholesterol, and they found that elevated total serum cholesterol, low HDL, and high serum cholesterol to HDL ratio were not associated with significantly higher rate in the all-cause mortality, coronary heart disease, hospitalizations due to heart attacks. And so this is all for, again, for people that were older than 70, okay? So this is a Journal of American Medical Association from 1994, actually. So that's one article there. Here's another one that shows LDL, so that low density lipoprotein, what we consider generally a bad cholesterol, is not a cause for cardiovascular disease. And again, like, it's not a cause for cardiovascular disease. Yes, LDL sometimes is correlated with cardiovascular disease, but there are other factors that I want to get to. So here they just have the commentary. Our search for falsifications of the cholesterol hypothesis confirms that it is unable to satisfy criteria for causality. And the conclusions of authors of the 3 reviews have misleading statistics, exclusion of unsuccessful trials, and ignoring contradictory observations. So this basically, they looked at multiple articles, multiple review articles, and they said that they cannot clearly say that LDL is a cause for heart disease, a cause for cardiovascular disease. So then we go to another paper and we say, okay, so lipid levels are inversely associated with infectious and all-cause mortality. So they looked at LDL cholesterol, they looked at total cholesterol, they also looked at triglycerides, I believe down here, and what they found is that higher LDL, higher HDL, and higher triglycerides were independently, meaning that each one of them separately were independently associated, again, it's just correlation, with all-cause death risk being lower. Neither LDL nor triglycerides were associated with cardiovascular death, and HDL was associated with lower cardiovascular risk. As we kind of already know, this is that good cholesterol. At the same time, LDL cholesterol was associated with reduced all-cause infectious, but not the cardiovascular mortality, so infectious mortality, which resulted in inverse association with all-cause mortality. So the whole point of living is to continue to live, right? And so, yes, LDL cholesterol doesn't, if we have an increased amount, it doesn't necessarily correlate with cardiovascular mortality, and it doesn't lower cardiovascular mortality as well. So that's why there are other factors. But it does reduce all-cause mortality and infectious disease. And that's because LDL actually improves our reaction to viruses and bacteria that come into our blood. And that's because when we do have these little rips in our arteries, what's happening is that it's going there to heal it up and protect it, and then protect us from other infectious illnesses. And then, so then lastly, what is the cause? Well, I'm just going to talk about one possibility here. So this is an older article from 1996. It's called Hyperinsulinemia is an independent risk factor for ischemic heart disease, cardiovascular disease, those kind of things. And so insulin is something that we generally say that too much insulin leads to then a lack of production from our pancreas, which then generally leads to type 2 diabetes, okay? But insulin as well can be inflammatory. And so if we have too much inflammation in our body with a high LDL, a high cholesterol, so both of them together, then that can probably lead to these fatty plaques, because we're not only getting these rips and tears, but then once the LDL goes in, it gets inflamed and it can't get out. And so let's just go right to the conclusion that the higher fasting insulin concentrations appear to be an independent predictor of this ischemic heart disease in men. Again, this was just another correlation study, an epidemiological study, but it showed that it was an independent predictor. So taking for account whether people had high or low cholesterol, high or low LDL cholesterol, high or low triglycerides, they adjusted for all that. That's where it says right here, adjustment for the multivariable and multivariate analysis for all these things. It was high insulin that was the independent risk factor. And we know that insulin, high insulin, can be caused by multiple factors. So let's talk about those real quick. So high insulin can be caused by eating too many refined carbs, refined sugar, refined vegetable oils. Those are the 3 big ones. And we really want to avoid that high amount of insulin chronically. This is where fasting can come in to lower that. This is where a ketogenic diet can come in to, again, lower that insulin level. Even though a ketogenic diet may increase cholesterol. But again, like as these studies kind of point out, cholesterol may not be the issue. It may be high cholesterol with other factors, with high blood sugar, with high insulin, things that are causing other inflammatory insults in our body, like those refined carbs, refined sugar, refined oils. So it's better to find whole foods, whole vegetable, fruit sources, good meat with high saturated fat, lack of those polyunsaturated fats that do cause the oxidation, the unstable fats. So I know this was a long one. I hope you learned something today, because a lot of people don't really understand cholesterol and how this cholesterol hypothesis maybe has shaped our culture and our eating, and even our governmental guidelines. And I think that we really need to look deeper into it. There have been plenty of studies that have been trying to counter it, and many are valuable and worth reading. So these are just a couple that I thought were valuable, and I hope you enjoyed it. I hope you got something out of it. If you have any questions or comments, please leave them below. I'm happy to answer. If you have any suggestions for future topics, I would love to answer them as well, and take those suggestions. So thank you, and stay healthy.